symptoms of sexually transmitted diseases, vaginal discharge, ulcers, vesicles, pelvic pain, discomfort during intercourse, herpes simplex type 2, vesicles, they appear in 3 to 7 days after intercourse. Human papillomavirus and lower genital tract, seen in the vagina, cervix, and causes chronic infection. So trichomonas vaginalis, we talked about that, we talked about males. So again, the organisms, you remember the organism that the picture we showed you the picture again. So that can cause sexual transmitted disease, candida, another type of disease, characterized by the appearance of branching pseudohyphae. The discharge in candida would be curved-like whitish vaginal discharge. So when we talk about the discharge, that sometimes can help and identify what type of sexually transmitted disease. So when we say that it is pseudohyphae, anytime that we tell you that the organism is pseudohyphae, and we talk about candida. When we say that this discharge is vaginal discharge is curved like whitish, then that's associated with this candida. When we talk about flagellated organism, then we're talking about trichomonas. Anytime we talk about bacterial vaginosis, when we say blue cells, that's bacterial vaginosis. Emphysizing herpes simplex, we see that herpes simplex has type 1 and type 2. So the description and what that detail about the description that don't worry about it, just read it for your understanding, but I want you to know herpes simplex type and 2, that type generally around the mouth, 2 in the genital areas, but can be seen anywhere because of sexual practice. Pelvic inflammatory disease, PID. It's important to understand this. This is basically an acidic infection that goes from the vulva of the vagina and goes upward into the uterus and the ovaries. So these patients, they present with pelvic pain and the pain in the axial parts. If you feel that you do vaginal exam and you feel the sides, admixture pain, you feel the sides of the vaginal canal, the females will complain of pain. The most common organism that causes pelvic inflammatory disease, the two most common is gonorrhea and chlamydia. So please remember, pelvic inflammatory disease is caused most commonly by gonorrhea and chlamydia. It is a type of acidic infection that can lead to pelvic pain, to fever, vaginal discharge. And the important thing about this pelvic inflammatory disease that can lead to complications. And the major complications of pelvic inflammatory disease is ectopic pregnancy. Ectopic pregnancy. Why ectopic pregnancy? Because this pelvic inflammatory disease, it causes inflammation of the fallopian tubes. So the ovum generally is produced by the ovary. It goes to the fallopian tube and it meets the sperm in the fallopian tube, as you know normally. So this inflammation in the fallopian tube, after this zygote formation, it may not go to the uterine cavity to become the normal pregnancy. It may stay in the fallopian tube because the fallopian tube is scarred from recurrent inflammation. And you remember, I always remember that when we tell you about acute inflammation generally heals. 90% of the time acute inflammation may heal without leaving any problems. But sometimes 10% of acute inflammations, they become chronic. And if it is recurrent, it is more likely to become chronic. And chronic inflammation heals by what? Fibrosis. Exactly. So recurrent inflammations, recurrent pelvic inflammatory disease, if it involves the fallopian tube, it can lead to scarring. So when the ovum is fertilized by the sperm, it may not be able to go to the uterine cavity to implant there and make the normal pregnancy. So after it is fertilized, it may not be able to go to the uterus, and it is arrested there, or a sort of prevented from moving, could not move because of scarring, and that leads to ectopic pregnancy. And that's how ectopic pregnancy is one of the complications of pelvic inflammatory disease. Another complication is sterility. Sterility is another complication of pelvic inflammatory disease for the same reason. That if the fallopian tubes on both sides they become scarred, the lumen is closed, then the sperm cannot reach the ovum, or the ovum cannot reach to meet the sperm in the fallopian tube for fertilization. So the most common complications of pelvic inflammatory disease is ectopic pregnancy and sterility. And if there is ectopic pregnancy, what is the complication of ectopic pregnancy? There is pregnancy in the fallopian tube. Rupture. So it may rupture and can create a lot of problems. Rupture of fallopian tube can lead to peritonitis, inflammation of the peritoneal cavity. So that's another complication. Cervical cancer. One of the cancers, females, that I want you to understand. This cancer was very, very common cancer before the introduction of what test? What is the test? Pap smear. Thank you. So pap smear reduced the incidence of this cervical cancer from being number one cancer in females. So that helped to recognize any abnormality in the cervix at very, very early stage. So millions of women, they are infected by human papillomavirus, and this human papillomavirus can lead to the development of cervical cancer. But because pap smear, that many of these women, they were diagnosed at very early stage. So please be aware about the association between the human papillomavirus and cervical cancer, and what type of strains of the virus that are responsible for cancer. The high-risk strains are 16, 18, 31, 33, and the low risk 6 and 11. And generally we don't worry about 6 and 11 when we do the strain diagnosis. If the 6 and 11, we don't follow up on these patients. But if the 16 and 11, we may remove that part of the cervix where it has, in the beginning, it will not start as cancer, it will start in the beginning as what? The initial stage will be in the form of dysplasia. Dysplasia, you know dysplasia, we talked about when we talked about cancer. So here, this is how it develops from normal to become cancer. It goes through stages. So initially, it will be in the form of dysplasia. And you know what we mean by dysplasia? The cells, they become larger, the nucleus become larger, the nuclear membrane become irregular, right? There may be mitotic figures. So that is the precancerous stage, when the cells, they start becoming abnormal. That is the dysplasia. They are not fully cancer, they are not full-blown cancer, but they are not normal. So that stage in between, we call it dysplasia. So that's why when we examine these patients and we find this stage, that we remove that part to prevent the development of cancer. So this is what we call it, the abnormal cervical cells when the nucleus enlarged, and this is the normal. You can appreciate that the nucleus is small, and you can compare it to this. So when we examine by pap smear and we see this finding, then we have to tell the patient that this is there. You have to change your lifestyle, and sometimes we may remove this part. Condyloma, this is a sexually transmitted disease, and it can involve any part, the vaginal canal, the vagina, the vulva, the anal area, perianal area, and that is sexually transmitted disease again. So what are the risk factors for cervical cancer? Early age at first intercourse, increased parity, a male partner with multiple previous partners, and of course a male that is infected by human papillomavirus. So don't worry about this VLCI and 1, 2, and 3. Uterus, just know the normal uterus. Now I want to know about a condition called adenomyosis, and the next condition, endometriosis. How to differentiate between these two conditions? What is adenomyosis? Now when we talk about the uterus, I want you to understand the normal tissue of the uterus, that you have the uterine cavity, then you have the myometrium, and then you have the outer part of the uterus. So in the lining of the uterus, you have the uterine glands. So when we talk about adenomyosis, this is the presence of endometrial glands and stroma within the myometrium. So these glands, they are supposed to be in the superficial layer. But if they are deep into the myometrium, that creates a condition called adenomyosis. So adenomyosis is the presence of endometrial glands and stroma in the myometrium. What is the importance of this? Why you consider this pathology? Because this can lead to excessive bleeding during menstrual cycle. We call it menorrhagia. Can lead to colicky pain, dyspareunia, pain, sexual intercourse, pelvic pain. And this is what exactly that is the presence of this gland within the myometrium. What is endometriosis? Endometriosis is the same, is practically the same, the presence of the endometrial gland within the myometrium, but more than that, it is also present outside the uterus. So this is the real difference between endometriosis and adenomyosis. Adenomyosis is the presence of uterine glands within the myometrium, but endometriosis is the presence of these uterine glands, endometrial glands, not only in the myometrium, but they are also present outside the uterus. They can be present in the ovary, and they can be present in the gastrointestinal tract, in the colon. So, if you are at the presence of endometrial glands in the myometrium of the uterus, as well as in the colon, what is that condition? Is endometriosis. But if the endometrial glands are only present in the myometrium of the uterus, it is adenomyosis. What is the complication of endometriosis? Now you know that we are having now endometrial tissue that is present in the colon. Believe it it or not, that this part of tissue, the endometrial tissue that is present in the colon, will be subject to the same factors like the uterus. Meaning what? That estrogen, that it will have this menstrual cycle phases, the same like the uterus. So during the menstrual cycle, in the early phase, this tissue in the endometrial tissue in the colon will increase, and if these hormone levels they come down, when there is no pregnancy, this tissue will be sloughed and there will be bleeding. And these people will have bleeding from the rectum. So rectal bleeding can be part of endometriosis. So please be aware of this condition. That if you are given a scenario that if I tell you that a female that came complaining of rectal bleeding and the biopsy was done and found that tissue has endometrial glands, what is the likely diagnosis? So please remember, endometriosis, presence of endometrial glands outside the uterus is called endometriosis. And these patients will be subjected to the same phases like the menstrual cycle. They will have bleeding, they will have pain, and they will have other stuff. Sometimes they may have intestinal obstruction when that tissue will proliferate during the menstrual period. So, this is just for your understanding. Endometrial carcinoma, this is cancer of the uterus. Leiomyoma, very common condition. That's why I want you to know it. What is leiomyoma? Leiomyoma is a benign tumor that arises from the myometrium. Benign tumor that arises from the myometrium. It's very common condition. That generally females by the age of 35, 40, they find that they generally have this leiomyoma, which are benign tumors. So these, now we mentioned that the uterus has 3 layers. So these tumors, they are benign tumors, they can be within the myometrium, they can be on the serosal part outside, on the outer part of the uterus, and they can be on the endometrium, in the inner part of the uterus. So they are in the inner part of the uterus and they attain large size, they can lead to abortion. Why they can lead to abortion? Because suppose that this female becomes pregnant and she has a large leiomyoma occupying the uterine cavity, the fetus will not be able to enlarge, to grow. So there will be abortion. Now these leiomyomas also, they may attain large size. And sometimes there is no enough blood supply to this large tumor, and there will happen what we call it infarction of these leiomyomas, and that can result in severe pain to these females. So remember that there is a condition called chocolate cyst of the ovary. And that chocolate cyst of the ovary, when you have endometriosis, I told you, endometriosis is the presence of endometrial tissue outside the uterus. So it can be in the ovary. So it may bleed like the menstrual cycle, exactly the same. So in the ovary there is bleeding because of endometriosis, it will collect within a cyst called chocolate cyst. Why chocolate cyst? Because it will get blood, and the blood with time becomes brown color. That's called chocolate cyst. So please remember, anytime we say about this condition, chocolate cyst of the ovary, practically it is endometrial tissue that is present there, and the condition is called endometriosis of the ovary. This is the endometriosis of our chocolate system. This is ovarian carcinoma. 3% of all female cancers, and these are the risk factors for ovarian carcinoma. You need to remember the risk factors for ovarian carcinoma. Non-infertility, those females that they don't become pregnant, they are increased risk for ovarian cancer. Why? Because when you have pregnancy, lactation, then the ovary is not subjected all the time to the effect of these hormones. So when there is, that you have pregnancy, the menstrual cycle stops. But when there's no pregnancy, there's all the time that the ovary is subjected to the high levels of these hormones that can lead to cancer. Transit families, there are familial cases. Can be unilateral, can be bilateral. So the detail of this, don't worry about that. That's for residents, for medical students, keratoma of the ovary. Keratoma, you remember what we talked about keratoma? It has all these 3 layers. So that can develop from the testis and can develop from the ovary. So if you are told that a patient presented with ovarian mass, and when the tumor was biopsied, the pathological exam found the presence of skin tissue, presence of nails, presence of teeth, then you know that it is keratoma. So you can appreciate that these teeth. So if you are shown the image, so please be familiar with this keratoma. There is an important tumor. The name is called Krakenberg tumor. This is here, Krakenberg tumor. What is Krakenberg tumor? You remember when we talked about the GI, if you remember? I told you that don't confuse it like Eisenmenger syndrome, that means right to left or right. Krakenberg tumor is a stomach cancer that metastasizes to the ovary. It's not the other way around. And then we have the breast pathology. Benign condition called fibroadenoma. It's a benign tumor seen in all ages, but more commonly in young females. There is no risk for these fibroadenomas to become cancer. And sometimes these young females, because the phobia about breast cancer sometimes bring these females when they feel this mass in the breast. So these females, they have, this mass, and when you feel it, that it can move from one place to place, that's very easy movable. That's fibroadenoma, it's a benign tumor, does not become cancer. Carcinoma of the breast is important, and I want you to know about carcinoma of the breast. And the carcinoma of the breast, I want you to know it from different points. Note from the fact the screening, how we do the screening. We do it by something called, what's the screening test? Mammogram. And when we start doing the mammogram at the age of 40. But if there is a family history, we do the mammogram early, at the age of 35. And I want you to know about breast carcinoma also. But can be a good prognosis and what can be a bad prognosis, and we'll talk about that. These are the risk factors for breast cancer. So, age, early age at menarche, age at first live birth, first degree relative with breast cancer will increase the risk for an individual to have breast cancer. And what we mean by first degree relative, a sister, daughter, or mother. It's not an aunt. Aunt is not a first degree relative. So please be careful when you are given a scenario. Say that an aunt is found to have, for a female, that their aunt was discovered to have cancer. That's not related. It's not a first degree relative. But if you say that their sister, was found to have cancer 2 years earlier, that is a risk factor. That increases the risk for this individual to have cancer. Yes. First degree relative. Estrogen, those who take contraceptive pills. Large size breast or breast density. Exposure to radiation. Somebody have radiotherapy for another cancer, for bone, whatever cancer, may develop breast cancer. Cancer of the other breast may increase the risk for that breast to have cancer. Breastfeeding will reduce the rate of cancer. Tobacco, smoking will increase. Obesity, overweight will increase the risk of cancer. Now there are certain hereditary factors that can increase the risk for breast cancer. And that is called BRCA1 and BRCA2. These genes, any mutation in these genes, BRCA1, BRCA2, can increase the risk for breast cancer. Now there are, when we talk about breast cancer, to start as carcinoma in situ. When we talk about adenocarcinoma of the breast, as you know that adenocarcinoma, anytime we say adenocarcinoma, starts from the gland, So if the cancer is present only in the gland, it is carcinoma in situ. And we call it ductal carcinoma in situ. But if it is in the lobule of the breast, it's called lobular carcinoma in situ. But if it is outside the gland, outside the duct, outside the lobule, then it is spread. It is invasive. So here these are the important factors, and they are practical things, practical points I want you to understand when we talk about breast cancer. So if we're talking about breast cancer that is not spread to lymph nodes, definitely would be better than a breast cancer that's spread to lymph nodes, right? And the breast cancer that is less than 2 centimeters will be better than breast cancer that is more than 2 centimeters. Okay. So the size of the tumor is important.
You said 2 centimeters?
Yeah, 2 centimeters is the cutoff point.
For the prognosis?
Yes. Or sometimes they put it as 1 centimeter, that's 10 millimeters. So if it is less than centimeter, definitely that will be good prognosis. Presence of lymph node metastasis, no lymph node metastasis is a good prognosis. And sometimes we talk about the grade. If you recall the lecture about neoplasm that I gave you, we talked about the grade, what we mean by the grading of this. We say that cancer is well differentiated or poorly differentiated, if you remember. Well differentiated, that it looks almost like the tissue of origin. When it is well differentiated, good prognosis. When it is poorly differentiated, bad prognosis. So the grade of the tumor also factor for prognosis. So well-differentiated breast cancer is having a better prognosis than a poorly differentiated breast cancer. Again, presence of distant metastasis. A cancer that has metastasis in the brain, definitely poor prognosis. Metastasis in the lung, poor prognosis. But if metastasis is in the other parts of the breast, definitely will be better than metastasis in the lung body. Another important factor about prognosis, any time that you are given in the scenario is very important. When we talk about breast cancer, and I tell you that this breast cancer was found to be positive for estrogen. There are breast cancers that they can be stimulated by estrogen. So estrogen will stimulate them, make them worse. So presence of positive receptors for estrogen is a good prognosis. Then you may ask me, how come that you say that estrogen will make the cancer worse, will grow in size rapidly, and how can be a good prognosis? That's a legitimate question. But why it is a good prognosis? Because if this breast cancer is found to be positive for estrogen, that is good prognosis from the treatment point of view. Meaning that if we give them anti-estrogen, we can stop the growth of that cancer. That's why a breast cancer that is positive for estrogen has good prognosis. What is the anti-estrogen drug that we use? Anybody knows? Tamoxifen. That is the drug that is generally used as. So, a breast cancer that expresses estrogen or progesterone has a better prognosis than a breast cancer that is negative for estrogen or progesterone. Is that clear? Another marker, that is a gene called HER2. This gene, the presence of this gene in a breast cancer will make that breast cancer poor prognosis, because it means that this cancer is very aggressive and generally does not respond to treatment. Even when you remove the cancer, there will be recurrence. So, if you are given a scenario that the patient has a history of breast cancer, and when the biopsy was done, the breast cancer was positive for HER2, what is the prognosis for this patient? Good, poor, or does it make a difference? It is poor prognosis. Any questions? So, do you need Dr. Shukrani to talk about this breast cancer? Okay, so I will tell him no need because I just